Okay, team, listen up. We're on final approach here. It's time to synthesize all the intel from Series E4 on diabetes and metabolism. This is it, the final unification. I need you focused.
Okay, here's the deal. To rule the diabetes empire, you gotta synchronize the logic gates. Your patient has heart failure? Bam! You bypass the whole ladder, go straight to the SGLT2 inhibitors. They wake up with high blood sugar, you check that 3 a.m. reading. If it's low, it's Samoji. High, it's the dawn phenomenon. See? This is not just about sugar anymore. It's about protecting organs, it's about survival. You either master this master tree or you lose the board. Let's go.
All right, before we dive into the metabolic frontier, we have our mandatory disclaimer. Please understand, this content is strictly for educational purposes, for exam prep only. This is not medical advice. Always, and I mean always, consult official guidelines for any clinical decisions.
Okay, let's get to it. We're going to construct the final master logic gate, and I want you to pay close attention because this is the first, most critical decision point in all of modern diabetes management.
So, let's run a scenario. A new patient walks into your clinic. They've got type 2 diabetes, their A1C is, say, 8.5%. But here's the kicker. They also have established heart disease, right? Atherosclerotic cardiovascular disease. So what's the mandatory first shunt? Where does your algorithm have to go right from the start?
And the answer, my friends, is all about this core principle, the comorbidity shunt. We're not just chasing the A1C anymore. The new doctrine, the new way of thinking, is to go after the highest risk factor first. And a lot of the time, that's the heart or the kidneys, not just some number on a lab report.
So the protocol is crystal clear. Step 1, you identify if those high-risk conditions are there. You know, ASCVD, heart failure, CKD. If they are, you immediately bypass what I like to call the metformin-only waiting room. You don't wait. You initiate a GLP-1 or an SGLT2 inhibitor right then and there. And why? Well, think about it. If we sit around and wait for metformin to fail, the patient's organs are going to fail first. We can't let that happen. Okay, let's switch gears. I'm about to give you some high-level intel on a really high-stakes error. This is one of those ultimate board exam traps, a critical gap in logic that in the real world can have absolutely lethal consequences. We're talking about the ICU bridge trap.
So picture this, you're in the ICU, you've got a DKA patient who's finally getting better. Their anion gap, it just closed. Awesome. They're still on an insulin drip. Now, the intern on duty, they want to stop the drip and then kind of, figure out the subcutaneous long-acting dose later. So is that the right move? What do you think?
No, absolutely not. And that's the trap. You never disconnect the IV insulin until that subcutaneous bridge is built and totally stable. The timeline is non-negotiable. First, you give the subcutaneous basal insulin. Then, and this is key, you keep that IV drip running for a full 2-hour overlap. It's only after that bridge is secure that you can safely stop the IV drip, period.
And let's be perfectly clear. This isn't some friendly suggestion. It is a hard and fast rule. If you leave a patient with 0 insulin in their system, even for a moment, they will slide right back into ketosis. You have to bridge that gap, or that metabolic storm, it comes right back.
All right, time to lock and load. We need to hardwire this logic into your brain so it becomes automatic. We're running a neural encoding drill. Think of it as your diabetes compass. This is going to be rapid fire. Let's lock it in.
First line for heart failure.
That's SGLT2 inhibitors. It's the mandatory shunt for protecting that organ.
What if your patient needs massive weight loss?
You're reaching for the GLP-1 receptor agonists. They are the absolute heavy hitters for weight reduction.
Okay, tricky one. Anion gap is still open, but the glucose is dropped down to 200. What's the play?
You keep that insulin going, but you add dextrose to the IV fluids. You got to close the gap, not chase the sugar.
What about high sugar in the morning, but you find out they had a low reading at 3 a.m.?
That's the classic Samoji effect. The move? You have to reduce the basal insulin dose.
Last one. Your patient's eGFR drops below 30. What do?
You stop metformin immediately, no questions asked. The risk of lactic acidosis is just way too high.
And right there, that drill brilliantly illustrates the entire philosophy behind this whole synthesis. See, it's not about just memorizing an endless list of facts. It's about really understanding the underlying logic. Once you truly get the why, the what just becomes second nature. It clicks.
And with that, we conclude our mission debrief. The logic gates are now synchronized.
The diabetes empire is secure. You've now mastered the core logic of Series E4. But listen, the endocrine system, it's a vast, interconnected network. It's full of these complex clusters. You've got situations where the body attacks multiple glands at once, or genetic syndromes that trigger tumors from the brain all the way down to the adrenals. This requires mastering syndrome logic. And if you can't navigate the complex shunts of the MEN types or the autoimmune polyglandular syndromes, well then you are just not ready for the final boards.
So, let's confirm your mission status. Series E4, the diabetes empire, is officially secured. Check. And your next target has been acquired. Series E5, global endocrine syndromes. It's time to prepare for the next phase.